Hey, good morning, everyone, and welcome to Euronurse. I'm your host, Vic Sinise. Good to see everybody here today on this. Boy, this fall is kind of a crazy fall for us. We've been having really warm weather. I'm not complaining. I like it a little cooler sometimes, but it is what it is. So let's get on with our show here. If this is your first time checking us out, be sure to go to our website at euronurse.com to learn more about the show, what upcoming shows there are, look at all our other podcasts we have available. All of our past episodes are available on our website. And hey, there's a link to our audio podcast. If you like to listen in your car and you got that long commute, what better way can there be than to check us out on our audio podcast? Also, if you haven't checked out, excuse me, Euronurse News, be sure to check that one out too. We got a great week coming up for you. We're going to be starting off with our Monday on let's see here. What are we doing on Monday? Yes. How we built the first AI generated genomes. On Tuesday, the AI that can forecast your health for the next 20 years. 43 The Pit. If you haven't watched that show, I have it. I heard it's really good. Emergency care on TV. But what about those hospital bills? On Thursday, Apple Watch can now detect high blood pressure, what you need to know. And on Friday, Doximity GPT upgraded. Instant answers, peer-reviewed clinicians. That's another one. If you haven't used that one before, it's really great. It's Chat GPT for us. We'll talk about how you can use that and how it's easily involved. Now, so I've got a little change here for our normal schedule. I've been doing this for quite a while. This is episode 165, and I got to tell you, quite frankly, I never had somebody not show up for the show. So this is a new one for me, but I'm always prepared. And I've tried something new. I've been approached by a lot of people that are in this industry, and they've got promoters that are out promoting them to other podcasts. So you're not dealing with our normal, I talk to somebody personally and, we kind of go back and forth. I'm talking to their person. And everything was set up for this week, but never showed. So I don't have any guests to do the athlete to innovator. But you know me, I'm always prepared. So I am prepared for this week. We are going to do something a little different. We're going to a contact hour thing. One of the things I've learned quite a bit about from doing all my news shows is some of these new treatments out there. And I found this really good 1 hour talk on well, let me tell you, it's the webcast that we're going to watch features expert faculty discussing overlapping symptoms and management strategies for overactive bladder and BPH. The program, led by Dr. Matt Rosenberg and David Staskins, aims to enhance clinicians' diagnostic accuracy and therapeutic decision-making in male and female patients experiencing lower urinary tract treatments. So this is this combination therapy that's kind of all the rage now. So we're going to get right into that and take it on right now. If you have any questions, feel free to put them in the comments. I'm here live, but this one is recorded.
Hello, everyone, and welcome to today's CME and CE presentation, OAB, BPH, addressing myths and improving outcomes. And we're here to challenge misconceptions, dive deeper into the latest evidence, and explore real-world strategies to improve patient care. I'm Ashlyn Smith, an adult endocrine physician associate, the immediate past president of the American Society of Endocrine PAs, adjunct assistant professor at Midwestern University, and a 2024, 2022, and 2019 America's Top PA Award winner. And it's my pleasure to guide you through this important discussion. And joining us today are two distinguished experts in this field. We have Dr. Matt Rosenberg, Director of Mid-Michigan Health Centers in Jackson, Michigan, and Chief Medical Officer of Wellvena in Nashville, Tennessee. And we have Dr. David Staskin, Director for the Center for Male and Female Pelvic Health at St. Elizabeth's Medical Center and Associate Professor of Urology at Tufts University School of Medicine in Boston, Massachusetts. Matt and David, welcome.
Good morning.
Morning.
David, good to see you.
We are thrilled to have you both here to illuminate these common and concerning issues. So let's jump right in. Here are the faculty for this program, and these are the learning objectives. And I'll hand it over to Drs. Rosenberg and Staskin, and I'll be back in just a bit with some audience questions. Go ahead and take it away.
Ashlyn, thank you so much. And Dave, again, good morning. Good to see you. So let's set the stage today. Two patients walk into the clinic. The first one, Mrs. Placid, she's a 50-year-old female with a 2 to 3 year history of frequency 10 times, urgency times 5, nocturia times 2, with occasional urgent incontinence. Her physical exam is normal. We actually do some voiding dynamics when we ask the questions. She empties her bladder. She has a good stream, no double voiding. Her urinalysis is normal. So I want to ask the audience a question here. So you can see this. The question is, what would you recommend as treatment for this patient? Would you suspect a UTI and treat with antibiotics? Would you suspect overactive bladder and give an anticholinergic or a beta 3? Would you suspect vaginal atrophy and give estrogen therapy? Or would you suspect behavioral issues and try habit training? I'll give you just a second.
Well, Dr. Rosenberg, we have a little over 47% selecting B. They want to give an anticholinergic or beta 3 agonist, with 31% suspecting a UTI and wanting to give antibiotics. So I'll turn it back to you to talk about what would be the best option.
Well, interesting. Let's hold that thought for a second. So we see that a lot want OAB. All right. Her urinalysis was normal, so I'm really not suspecting UTI. And we said her physical exam was normal as well, so we wouldn't be thinking estrogen therapy, or really habit training is always a possibility, but we're painting a picture of OAB here. But remember, she came in with a friend. Actually, her friend is her husband, Mr. Placid. And he is 50 years old. He has all the same symptoms. His physical exam is normal. His voiding dynamics are the same as hers. Her urinalysis, like hers, is normal. So here's our ARS question for her. For him, what would you recommend as treatment for this fella? Would you suspect a UTI, giving antibiotics? Would you suspect OAB, give an anticholinergic or a beta 3? Would you suspect BPH and give an alpha blocker or a 5-alpha reductase inhibitor? Or would you suspect behavioral issues and treat accordingly?
So we do still have the majority, a little over 41% wanting to do an anticholinergic or beta 3 agonist. We do still have a few, 23% wanting to do antibiotics, and it's split evenly among the other two for Mr. Placid.
Okay. And what about C? What do we see there?
For C, we had about 17%. And then again, 17% for habit training.
Got it. Okay, great. Well, what's interesting is we have some different answers, some in the same way, but I want to kind of set Dave up. Dave, on this, why do we in the back of our heads or think about men differently than women?
I think first of all, I think the audience did great. I mean, the real difference here is the prostate, which is essentially what we're going to talk about today, with the idea being that male patients have sort of the conundrum of both having issues with bladder outlet obstructive symptoms, hesitancy, incomplete emptying, poor flow, hip. And women have OAB as their primary diagnosis, usually with these symptoms: frequency, urgency, nocturia, fun. So the idea here, again, is in the female patient, we tend to think OAB. In the male patient, we tend to think BPH. But we're going to sort of dive into this a little bit and try to make us all better clinicians and get better care of these patients.
Great. So when you spoke about bladder just a second ago, David, and OAB, and really this is one of the things what we're talking about today. And what's interesting is the prevalence of OAB as we get older is the same as it is for men and women. Dave, you want to talk about that a little bit?
Well, obviously, as you showed in the graph, OAB is equally prevalent. The symptoms of frequency, urgency, and nocturia do sort of overlap or are included in BPH symptoms. Whether this is because of the obstruction or not or whether clinicians feel hesitant to treat bladder because they suspect some bladder outlet obstruction is the conundrum. Men with LUTS are more likely to be treated with an alpha blocker, although our group did fairly well with Mr. Placid's history. And many men have persistent storage symptoms following treatment. That's the person that comes into your office with obstructive symptoms, gets treated, but has persistent frequency, urgency, and nocturia. Matt, why don't you sort of clarify the OAB symptoms for us?
Yeah, and Dave, thank you. When we talk about the bladder itself is a storage unit. The goal is to store urine and to empty urine. And since we're talking about the prostate as well, the prostate has a function is to create fluid for seminal emission, and then as we get older, stay out of the way. So let's talk about the symptoms of the bladder first. So OAB symptoms are storage and emptying issues. So if the bladder is not storing as much as it should, right, you're avoiding small amounts. You're going to be avoiding frequently during the day. You're going to avoid frequently at night, which is called nocturia, obviously. You're going to have urgency, which is that feeling like you have to rush to the bathroom. And along the way, you may leak as you're rushing to the bathroom because your bladder is spasming a little bit. You can have you can have OAB wet, all right, which is OAB with urinary urge incontinence, and OAB dry without that. So these are the bladder issues: frequency, urgency, nocturia. We talk about the prostate. Again, the prostate is supposed to stay out of the way as we get older. So if it doesn't stay out of the way, it affects flow. So you have poor flow, intermittency, sometimes dribbling. So that's how we delineate in our history between the bladder and the prostate. And Dave, you've written about this quite a bit, and you've shown me this many times. Can you talk about this in terms of how you engage a male patient?
Well, I think this is the crux of everything that we're presenting, really in one slide, because what we're saying is a patient comes in with poor flow, male patient, and no OAB symptoms or minimal, more obstructive than irritative, we would say. He's a good patient for a BPH med, usually an alpha blocker. If they have poor flow and OAB symptoms, the question is, if their flow is poor and you're a little bit hesitant in this patient to treat them for their bladder symptoms first without treating their outflow, you treat them with an alpha blocker, then consider treating for OAB if it persists. And a patient, though, that comes in with good flow, like Mr. Placid, and again, 50% of the group was on the right track here, and OAB symptoms, this is a man with OAB and minimal obstructive symptoms. If he has a good flow, empties his bladder well, and a negative urinalysis, go for it. Treat him for his OAB, which is what we did in that second question. And if someone's had their flow treated and their OAB symptoms do persist, because in a percentage of patients, they'll resolve with treatment, even more with surgical than medical treatment, then their OAB symptoms, when they persist, fine to treat them for OAB, and even more confidently because you know that they're not obstructed anymore. Let's talk a little bit about evaluation in the primary care setting, Matt. And I really enjoy this because I believe that this is a primary care disease. We're always happy to see these patients in our office. My advanced practice people love these patients. And why don't you go into a little bit about what kind of workup might precede that?
Yeah, Dave, I appreciate that. And it is interesting. I also believe that this is a primary care disease. And to be honest, I feel like in my world, we should be sending you the refractory patient, and we should start that initial therapy if we're comfortable. So the question is, how do we get comfortable? And if you look at the pathway here, we start with the initial diagnostic process, get a history. What are we looking for? We're actually looking for, are they having bladder symptoms or prostate symptoms? Is frequency, urgency, or is it a flow issue? And then we're looking at comorbid conditions that could be contributing to that. That's part of our history. Is it poorly controlled diabetes? Is it maybe hypertension and they're on a new diuretic or something like that? So we're looking for things that could be affecting our ability to handle fluid. The physical exam, we all know how to do. Don't need to tell my audience anything here, but do make sure to do a general urinary exam because that's the area they're complaining about. And certainly with a guy, a prostate exam is going to be appropriate. In regards to lab, a urinalysis for obvious reasons. You want to check a random or fasting blood sugar for possibly undiagnosed diabetes. And I do recommend a PSA because this is no longer screening. This patient is coming in with symptoms. With that, we can actually make a diagnosis. Now, if other things come up, for example, we're not sure, the urine's questionable, get a urine culture, all right? If there's blood, obviously you're going to refer that patient out. What about post-void residual, that assessment? We talked about that in one of the ARS questions. A little bit of a debate on that. If a patient has a good flow, when I say that, I'm making an arc with my hand. If you have a good arc to your void, the chance of you being obstructed is very low. The chance of you being in retention is low. So that ARS question we asked before, the answer was post-void residual, but that's going to be dealer's choice. If you feel like the patient has any obstruction and could be in retention, that's appropriate to get it. Bladder diaries, I love these because I'm looking for the patient who's voiding frequently of small amounts. It gives me an easy way to assess the volume that the patient's voiding. And the symptom questionnaires, we use the IPSS, the International Prostate Symptom Score, the AUASI. These are bladder and prostate scores, which are useful, but in primary care, and Dave, you pointed this out, I probably have 100 questionnaires. So I'm going to be knowledgeable about the information, but I'm not necessarily going to use it. So in my work up to this point, I'm seeing if I can treat the patient empirically, if I'm comfortable, and then if I'm not or something shows up, that's where I'm going to be, calling Dave and saying, Dave, can you help me with that complicated or refractory patient? What would you say to that, Dave?
I'd agree with you, Matt. And again, the IPSS score is frequency, urgency, and nocturia. You can ask those questions, and then the flow questions. So I like the IPS. We use it as a screener in my office. Almost everyone with voiding symptoms fills it out. We can follow them if we give them treatment. I understand what the issue is with 100 different forms in that lower right-hand desk drawer as you're speaking to everybody. And flow and PVR, we have a flow meter. People are able to void in a funnel, which measures flow electronically, and we're able to do a post-void residual with a small bladder scanner. So again, this is a great patient for my APPs. They can know that a patient empties. They can re-ask the questions. They can institute therapy, and then they can follow up to see the response. Antimuscarinics, which block the binding of acetylcholine to the cholinergic receptors that cause contraction in the bladder. Those are in red. The beta-3 agonists actually stimulate the beta-3 receptor on the bladder. In the bladder, 97% of beta receptors are beta-3. So it's it's actually very specific for bladder. And norepinephrine is the neurotransmitter. As you know, down at the bladder neck, it's alpha blockers and alpha reductase inhibitors, which actually relax the prostate. So we're really dealing with two different mechanisms for modulating the detrusor, and we're looking at two different mechanisms for modulating prostate size. Matt, why don't you cover a little bit of this on antimuscarinics? This anticholinergic load issue it's been an interest of mine for about 10 years now, and we keep finding out more things about it.
Oh, yeah. Dave, you and I have been talking about it, and the studies have shown concerns with the anticholinergic drugs. Unfortunately, sometimes the society recommendations take a little bit of time to catch up on that. But when we look at the anticholinergic drugs, what we have to worry about is the effect on the elderly population. And you see a lot of data here. It's basically showing that the anticholinergics can affect the cognitive issues or cause cognitive impairment in our elderly population. So be very careful, not only for the individual anticholinergic, but for the anticholinergic load. And as we see here at the bottom of the slide, the antimuscarinics are on the Beers list, which is saying to be cautious with that. Now, the AUA put a statement out saying, or their white paper on the Beers criteria, and basically saying use this cautiously. If you're going to be using an anticholinergic medication in the elderly population, be careful. In fact, a lot of us are saying you really shouldn't be using this. Try to stay away from that. And what's really interesting here is, there we go. What's really interesting is that, and at least I thought this for years, that, well, if you use the anticholinergics for a short period of time, you're going to be okay, but the longer period of time, it's not. That's when it gets affected. But actually, the studies, this is a meta-analysis of all the studies, have shown that even within 3 months of use for the anticholinergics, you can have that incident dementia. So this was an amazing study that was put out by a friend of ours, and it really kind of changes the way we think about it. And the bottom line is elderly population, anticholinergic, be careful. And all the major societies are saying that right now, which brings us to safety and efficacy data for the set of drugs we're talking about today, David. And I'd like to start with a case here. And let's go to Mrs. Waters. And she is an 80-year-old female. She has a 3 to 4 year history of frequency 12 times, urgency 6, nocturia 3, urgency incontinence 2 to 3, history of confusion with prior anticholinergic administration, consistent with what we were talking about before. She has a past medical history of depression and GERD. Her voiding dynamics are good. She empties her bladder. She has a good stream, no double voiding. Her urinalysis is normal. Her meds are paroxetine and omeprazole. So an ARS question for our group: do you suspect a UTI and you'd give antibiotics? Are you suspecting OAB and use an anticholinergic? Or suspecting OAB using a beta-3? Or are you suspecting behavioral issues and you're going to recommend habit training and reassurance?
All right, let's see how our audience answered. We have a little over 50%, 51% wanting a beta-3 agonist. Well done. And then we have close to about 20% wanting antibiotics and about 20% wanting anticholinergics. So vast majority wanting to do a beta-3 agonist. Wonderful, very astute. I'll turn it back over to you for why that might be the right choice.
Yeah, good job with the audience on that. Certainly using a beta-3 is safer. We talked about the anticholinergic effect. And in fact, Mrs. Waters had a problem with her prior anticholinergic effect. So we really don't want to use that. And the UA was normal. I certainly see everyone's point of wanting to treat that, especially in the elderly patient. We'd love to get a culture to prove it first. But in this case, her urine was normal. So kind of thinking something else, in this case, OAB is appropriate in using the beta-3. But let's dive into the beta-3s a little bit. Dave, I'd like you to start talking about some of the adverse events, and you authored a lot of these papers, so I'm looking forward to this.
Yeah, well, actually, we can do it pretty simply, Matt. This was a study that used an antimuscarinic tolterodine on the right side in a study with Vibegron recently published in the Journal of Urology. And what you really can do here is just to say, where is my dry mouth? Where is my constipation? Where's my blurry vision that I'll often see with the antimuscarinics? And it's not seen with the beta-3s. The safety data on CNS doesn't normally show up in these clinical studies, and it probably should. There should probably be more investigation of that symptom with questionnaires of some type. But you're really not seeing this. And this is the Vibegron data, and this is the mirabegron data. And this is the mirabegron data against common adverse events using total antimuscarinics from other data. And as you can see, you're not seeing two things in this. You're not seeing the antimuscarinic effects, dry mouth, constipation, blurry vision. And you're not seeing hypertension or tachycardia, because these are beta-3 and not beta-1 specific drugs. So you're really not seeing some of the beta-1 problems, and you're not seeing the antimuscarinic issues. There are some differences in the package inserts between mirabegron and Vibegron. Just quickly, you can read this or come back to it. You should always look at the package inserts briefly if you get an opportunity when you're prescribing something. Vibegron is a fixed dose at 75 without dose adjusting. It does have some advantages as far as patients with renal and hepatic impairment because it's metabolized differently than mirabegron. From the drug-drug interaction, It does not use CYP2D6 in some of your patients, especially those on antidepressants and other drugs that use 2D6. The Vibegron, which is actually metabolized by 3A4 and not clinically significant, becomes a much more useful drug there. There are some periodic hypertension measurements, blood pressure measurements recommended when mirabegron came out. That was not in the Vibegron label. Continuous blood pressure monitoring was done for a month in a cohort of patients and showed no effect on the beta-1 receptor type issue. And angioedema is both and will show up in all drugs sooner or later, and it's not related to class, but is probably related to individual patient reactions to drug.
So let's try a different case, Dave. We're going to go to a 65-year-old female, 3 to 4 year history of frequency. She has frequency 11 times, urgency 4 times, nocturia twice a night, and some urgent continence for 2 to 3 times. History of somnolence with anticholinergics. She has breast cancer, which is in remission, hypertension, and depression. Her physical exam and her voiding dynamics are normal, empties her bladder, good stream, no double voiding, and her labs, again, her urinalysis is normal. She's on tamoxifen, nebetalol, and fluoxetine. So an ARS question for the audience. Do you now suspect a UTI and you treat antibiotics? Suspect OAB, treat it with an anticholinergic. Suspecting OAB, trying with a beta-3, or suspect behavioral issues and try habit training and reassurance. Ashlyn, we'll give them a few seconds.
We actually had 100% of our audience selecting C, beta-3 agonists. So we had a very high amount selecting C for this patient. Well done.
Well, that's because they had the guy who wrote the papers doing this, David.
Well, can I just make a quick comment here, Matt? And
Yes.
This is very subtle. This is very subtle, but this is a very bright group. So let's take them to a little higher level. Tamoxifen is a 2D6 drug, and if it's inhibited or competed with by 2D6, it decreases the tamoxifen efficacy. All right. Nebivolol is a beta-1 drug, shouldn't have any interaction with the beta-3s. But again, tamoxifen at 2D6 and fluoxetine at 2D6. So you have two 2D6 drugs here. And we talk about anticholinergic load, but my prediction is that within a couple of years, as we increase our ability to cross-reference all these drugs, we'll start talking about 2D6 load also.
All right. That's a great point, which is a narrow pathway, and we want to avoid that. So a great job with the audience on that. So, and Dave, great job presenting it. Let's look at this next case. Now we're going to go a different direction. We have Mr. Johnson. He's 71. He is treated for his BPH, which has helped his flow and his bladder emptying, but he still has this urgency and nocturia. His history is the BPH. His physical exam is normal. His voiding dynamics are normal. Good bladder emptying, good urine stream, or he says it's improved, and his hesitancy is improved as well. His urine analysis is normal, and his medications are tamsulosin. So I'm not going to give everyone a chance to answer this because it's a little different. I want to know what we'd recommend for this treatment, but I'm going to throw this over to Dave, who's actually written a lot of the papers on this, on the treatment of men who still have symptoms with BPH.
Let's go back. These are the two papers I'm actually going to reference, talk about. One was done with mirabegron. I was happy to be an author on this. And the second was done on Vibegron, and I was the lead author on this study. And this is using add-on beta-3 therapy in men who are being treated for BPH pharmacologically. And just to go into a little bit more detail, because I'm even more familiar with the Vibegron study, you can see it's a very large study. And it really does look at the symptoms, the OAB symptoms that men had when they came, already treated for their outlet obstruction, and now wanting to be treated for their OAB, bothersome OAB symptoms. So if you look at this, micturitions is frequency, and there's placebo versus drug. There's always a placebo effect in the placebo group because of the keeping of bladder diaries and people really concentrating on their urinary symptoms. But this is a robust response by drug over placebo. Micturitions, volume voided. If you're not holding more in the bladder, then your drug's not having a pharmacologic effect. Urgency episodes. I think that people, interestingly enough, urgency is the symptom that men complain about, and women the most with OAB, that compelling need to go that interrupts what you're doing. Okay, so urgency leads to frequency. Urgency happens before an urge incontinence episode. And when you think about this, urgency is what drives people to get up out of bed at night when they'd much rather go back to sleep. UUI episodes, and we haven't talked about UUI in men. It's actually not as common. 50% of women with stress incontinence will have urge incontinence. Men will not show as much urge incontinence. They'll tend to be 85% of men will be OAB dry, but it really did have an impact on those men who did have accidents. And getting up at night, which is really sort of not nighttime frequency, but in this study was divided out based on time and voiding diary. And again, shows that effect on decreasing the voiding episodes at night. This is the IPSS storage scale. So it's just the frequency, urgency, nocturia symptoms, not the flow symptoms. The men were already treated for their flow, and shows a distinct improvement here, again, of drug over placebo using treatment for the men's OAB symptom. In an office where someone's focusing on flow, sometimes for symptoms like this, the men's alpha blocker will be doubled, and their problem is not flow. Their problem is OAB. They respond well to OAB treatment. This is just a little summary of the safety issues in the longer-term study. In the trial was 75 milligrams. There were improvements in all the things I just showed you, and it was very, very well tolerated. Back to you, Matt.
Yeah, thanks, Dave. I'm going to ask you a quick question on something you just mentioned on a prior slide. We don't need to go back to it, but where you spoke about a lot of times in primary care, or urologists probably as well, will double down on the tamsulosin because we're worried about flow and really not getting it right by doing that. You see that pretty often, don't you?
I actually, the most ironic time you see it is in the man that we talked about in the beginning, who has OAB symptoms and no flow problem, and gets an alpha blocker and doesn't get better because his problem wasn't flow. His problem was frequency, right, urgency, nocturia. And a lot of times he'll come back, and the doctor will even ask, "How's your flow?" And I'm sure the patient's a little bit embarrassed. I don't want to disappoint the doctor either, but they really didn't have a flow problem in the beginning. And now, if they're going to get double down on the alpha blocker, they're probably going to give up on treatment for a while altogether. So the person who's insightful and is able to separate those irritative frequency, urgency, nocturia symptoms from the obstructive ones, puts them on the right medication, is going to have the happy patient.
Yeah, no, that's a great point. So I think one of the pearls we can take out of this is, when we think about the patient coming in, before we think about doubling down on that tamsulosin, maybe we'd be thinking about a different diagnosis, which leads us back to
I was going to actually comment on Mr. Johnson, Matt. I didn't mean to interrupt you. Sorry, but
study that let us right back to Mr. Johnson. Go ahead.
Yeah, the study that I showed actually was designed to get treatment of OAB in men in the package label. So that's why it's there in the square. And you can use a beta-3 agonist. You can even use an antimuscarinic. But of all the OAB drugs, this study had the FDA very, very happy with data the way it was done. We were very proud of that. And it really did cause a package insert change for the treatment of men who are with OAB symptoms after treatment for their bladder outlet.
Oh, Dave, that's a fantastic point, and I really appreciate the data that you shared. And again, the pearl from this is, as we see Mr. Johnson, we had these symptoms, and opposed to just continuing to focus on the prostate, now we looked at the bladder, which is going to help. So let's go to our conclusion, and then we're going to take some questions. Our goal for today was talking about LUTs, and just as we talked about with Mr. Johnson, these guys will present with BPH and or OAB, as we're showing here. If we are, the similar symptoms are there for storage. If you treat those obstructive symptoms as we did with Mr. Johnson and residual symptoms occur, don't just think it could be the prostate still, start thinking about something else. And in this case, those residual OAB symptoms can be addressed. Be careful with the anticholinergics due to the CNS effects as well as the classic AEs. The beta-3s are safe. Dave did a great job pointing that out. They're effective in the male, which now has an indication, as well as the female and the elderly. Consider the anticholinergic burden. Consider the burden on the 2D6, just as David presented earlier. And most of this workup and most of this, the evaluation and initial treatment can be done in the primary care setting. It's for those cases that are refractory or we're uncertain after we've done that initial workup that we're going to send off to the urologist. And hopefully we'll be able to treat many more of these patients that are suffering in silence. And Dave made a very good point a minute ago. He said, look, in a lot of these cases, they double down on the tamsulosin. The patient gets frustrated, doesn't seek further treatment. As opposed to if we're opening our eyes, it's possibly OAB, we can treat that. And then when they're refractory, we can send them off to the urologist.
Now we have a good time for audience questions. And I will, I'll start with you, Dr. Rosenberg. Shirley asked if a patient has no urgency, that they have a full bladder, but they do not feel it, what kind of differential diagnosis should she be looking for?
That's a great question, Shirley. So when we talk about a full bladder, if a patient came into my office and said that, what I'd be interested is, are they retaining? And then why are they retaining? So the first thing I'm going to do is a physical exam. Frequently in my world, if a woman is retaining, it's either because of an anatomic or neurologic issues. If it's anatomic, for example, we're seeing a cystocele because they're certainly the bladder is tucking under and it's not able to empty from an anatomic standpoint. You could also see a urethral stricture or obstruction. I've seen that. It's not very common. Then I'm going to order a post-void residual on her. Okay. Now in my office, I do research, so I'm able to do that relatively quickly. If she's telling me she's full, then I should see a full bladder, right? So I may see 300, 400, 500 in there. That's if it's physiologically the problem. Now maybe she thinks it's full and she's voiding a lot, and then that's OAB. So if she's only holding 150, 200 mLs and only able to void and voids that complete amount, and then but feels full, then it's like, why is the bladder not functioning the way it should? So once I've done that, then I'm going to be able to make a determination. Is it a problem with the bladder being too full, or is actually that overactive bladder? And the other caveat to this is the neurologic. If she had a stroke, for example, recently, or not even that recently, if she had a stroke, any sort of neurologic problem like MS, you may see it as well.
Excellent. That really very practical clinical pearls there. Thank you. We had both Pamela and Hema feeling like if we have Vibegron, why would we choose Mirabegron? They're kind of wondering lower medication interactions. Overall seems to be a better choice. Kind of wondering, is there a place for Mirabegron?
I can take that, Matt.
Yeah,
I can take that. I mean, essentially, if you there's never been a comparative study, and the efficacy and safety of both drugs are good. There are some advantages according to the package insert, and there are probably some advantages based on the fact that Mirabegron has gone generic, so the pricing in some drug programs is going to be better. As long as you don't have a significant 2D6 problem, as long as you haven't seen hypertension with with mirabegron, then obviously you can use your judgment for that.
Excellent, thank you. I'll turn this one over to Dr. Rosenberg. We have a couple of people wondering about the I apologize. We have a couple of people wondering about the issue with the one of the case studies. There was a mention of statin intolerance. They're wondering if that plays a role in choosing which medication you would. Is that something we should be looking out for? Because a lot of our patients do experience those symptoms. So what should we be looking for? Is that a clue?
For statin intolerance,
Mhm.
you're saying? So, yeah, I certainly in primary care, I see statin intolerance all the time. And I get, as you know, it doesn't matter if you've taken the statin for a day or 10 years, somehow you can become intolerant to it. Having said that, I haven't seen a connection. If off the top of my mind, if I would say patients don't tolerate a drug are more likely to not tolerate a statin, I have not seen that. So, Dave, I'm going to ask you the same question. Have you seen a connection with some people not being able to tolerate statins and then they fall off on the antimuscarinics or the big
It's an interesting question, but not it's not a direct correlation. In other words, obesity and dyslipidemia have been shown to be tied to OAB. And someone asked me a question like this the other day. What about if you're using a drug like omeprazole? Does that cause OAB? And the answer is no, but it does decrease magnesium levels, and magnesium levels that are low have been related to OAB. So if you do these big demographic studies and you get all sorts of data, you try to look for these relationships. But the answer is no, there is no relationship between the drugs, only between dyslipidemia and the symptoms.
Excellent. I'll actually ask you, Dr. Shaskin, this next question. Peter was wondering if you do have somebody on an anticholinergic and they do experience some of those cognitive concerns, is that reversible once the medication is stopped?
To my knowledge, yes. I'm not an expert in this area, but I found that patients who do have a problem do get better. The only way I can describe this to people for understanding what it's like for some people is like when you take an antihistamine when you have allergies, and you're not demented in the very beginning. Obviously, you're not demented, but you just can't remember where you left your car keys. Or someone asks you what you did last night. You said, I watched a movie, and they say, what movie was it? And you can't remember. So it's sort of a little, people get a very mild form. It's not, red as a beet, crazy as a loon type of antimuscarinic problem. It's really just a little bit of a cognitive thing. And I see this even in some younger people.
Yeah. Ashlyn, I had a couple of cases like this. It's funny, those the unique cases always stand out in your mind. I had a patient who was demented and but okay, and was at home and had seen someone was put on an anticholinergic, and the family brought the patient in saying, it's just gotten too much. We saw the new drug, we stopped it, and it pushed them back just enough so they were able to stay home. So it really, and you see the case once, you're like, wow, this really is there. So, it is there, and it is something to be cognizant of. Sorry, no pun intended.
Well, thank you, Dr. Rosenberg. I'll have you answer the next question too. We have a question from Ursula wondering what kind of questionnaires that you use for these patients that come in.
Sure. So, Ursula, great question. If you have the time, the AUASI, the American Urologic Association Symptom Index, is great. The IPSS is great. The International Prostate Symptom Score is really good for delineating these things. You may not always have time, and that's what I have found in my practice, but I am knowledgeable to the questions. So what I would recommend that you do is look these up. You can get them readily online. Just look at the questions, and knowing the questions themselves will educate you on how to talk to a patient.
Excellent. We just have another minute or two for some questions. So I'll ask For you, Dr. Staskin, we had some people wondering about just kind of lifestyle impact on OAB. Shalene was asking, have environmental causes of OAB been studied in comparison to a medication? And somewhat similarly, Juan is asking about, caffeine related to OAB symptoms. So kind of comparing how those external and environmental factors might be addressing those might have an impact versus medications, whether we do have that data available.
Yeah, I know. I agree. I think that sort of habit training and looking at dietary issues. Some patients are more sensitive to this. Some patients, once they realize what's causing their problem, Matt always likes to tell a story, but just a quick one is I had a woman that came in every night and she used to get up, and I asked her about all of her habits, and it ended up that she used to drink a big brandy before she went to sleep. An elderly lady. She was very happy, pleasant in the office. And when we finally found out that that's if she stopped that she'd be better, she said, "I'd rather get up." So people make their own people make their own decisions. If someone comes into your office and while they're having their office visit with you, which can be very brief when you're busy, and they stop to reach and drink out of a water bottle, I can tell you without really sophisticated studies, that person drinks too much water. Okay, so there's a lot of things that people will do. And again, all the things like weight control and everything, and lowering weight control, improving weight control, etc., and avoiding foods which tend to, in some people, to irritate their bladder. All these things work.
Well, thank you so much, Dr. Rosenberg and Dr. Staskin, for your invaluable insights on OAB and BPH. And for our audience today, don't miss the downloadable clinical highlights on OAB and BPH.
All right. So hopefully that was interesting. I really liked the presentation, and I've been doing some, like I said, some reading on the subject with preparing for my Euronurse news. And I put a question out there if you like this format, because I've been toying around with in the future kind of using this format for some upcoming episodes where I get some experts on to talk about something and then kind of do a little Q&A with the audience during, like they did, where they ask the question and get the answer. And then kind of taking some questions like we always do at all of our shows that are live, like this one. So, just some thoughts. Got some positive feedback already from you guys, so that was always good. So let me see here. I got a little plug here for next week's show.
Could erectile dysfunction be linked to sleep apnea? In this eye-opening episode of Euronurse News, host Vic Sinise sits down with Kirk Huntsman, chairman, CEO, and co-founder of Vivos Therapeutics, to explore the overlooked connection between these two common conditions. Sleep apnea is often underdiagnosed, and its effects go far beyond snoring and daytime fatigue. New research shows it may play a major role in erectile dysfunction by disrupting oxygen flow, hormones, and cardiovascular health. Join us on October 4th at 9 a.m. Central Time to learn more.
Yeah, so join us next week for that. It's going to be an interesting talk with Kirk, who kind of invented this thing that helps with sleep apnea without that crazy machine that you see. So tune in if you want to learn more, especially if you suffer from sleep apnea. This, I think, is going to be helpful for a lot of people. As always, glad to be here for you guys every week. Enjoy coming here to you live on Euronurse, and we'll see everybody next week for that episode. And hey, keep the date open. 2 weeks, we are planning on being live at the SUNA conference in Louisville, Kentucky. It's coming up in a couple weeks. So we'll try to get that all set up for you to do a live talk like we did in the past at our conferences. Those are always fun. So the rest of you guys just have a nice weekend, and we'll see you next week.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the street. of dreams.